Good afternoon. My name is Rachel Quinn, and I am Special Assistant for Health Policy and Programs here at the Healthcare Authority. Today is the third webinar in our Paying for Values webinar series. The focus of today's webinar is on value-based benefit design and how it applies to our accountable care program. With me today is Dr. Mary Kay O'Neill. Dr. O'Neill is a partner at Mercer, where she assists purchasers of all sizes develop value-based purchasing strategies, including how to implement value-based benefit designs as well in those different strategies. Mercer was a key partner in helping the Healthcare Authority design and implement its accountable care program. And Dr. O'Neill has a lot of experience with, given she's a well-seasoned physician leader, has worked in different healthcare sectors, including health plans and delivery systems, and is with us today to lend her view on value-based benefit design and its importance in new payment models and healthcare health system transformation. Before I start, I want to do a couple of housekeeping reminders. One is there's two options for audio. You can use the microphone and speakers on your computer, or you can use the telephone. If you have a question, please use the online question pane available through the webinar. We will answer questions at the end of the webinar after we complete the slides. Also, the slides will be available for download in the handout section of your screen and will be on the Healthier Washington website after the webinar. I want to do a sound check right now. If you cannot hear us, please check if your speakers and headphones are turned off or plugged in, or if your PC is muted or the sound settings are correct. Or make sure your GoToWebinar sound settings are correct. If you're having problems, go to the GoToWebinar at www.gotowebinar.com for support, or join us via telephone. The dial-in number is in your email that you should have received when you registered for this webinar, and then click the plus in audio and then select Use Telephone. The purpose of today's webinar is to present the concept of value-based insurance design, talk about how it applies in the development, how it was developed and created under the Healthcare Authority's Accountable Care Program Act and used in other value-based programs under our Public Employee Benefit Program. And then Dr. O'Neill is going to talk about the importance of each stakeholder playing a role in value-based purchasing and value-based insurance design. And then last, we'll address any questions that come up during the webinar. So first, I wanted to set some context. The Healthcare Authority, along with other state partners, Department of Health and Department of Social and the DSHS, is working to achieve the triple aim, really better health, better care, and lower costs in Washington State, really driving towards achieving healthcare transformation in our state, so the health of communities improves, members' health, individual health improve, and that we achieve new payment structures to help support those changes we want to see. One of the biggest strategies that we're working on is our Paying for Value strategy. So the Healthcare Authority, which is the largest purchaser in Washington State, we purchase care for over 2.2 million people. We have a $10 billion annual budget. We're really trying to drive away from fee-for-service and driving towards improved outcomes and paying for value and value-based outcomes. In partnership with purchasers and providers and payers, we're working to leverage our purchasing power to move to 80% of the market from fee-for-service to value-based payments. We're testing, improving, and bringing to scale shared savings and cost of care models. We're also, in addition to our Paying for Value strategy, we're implementing Medicaid payment delivery models that support full integration of physical and behavioral health. But today I'm going to talk a little, the focus of today is how we're using value-based insurance design in our plans and how we developed under our accountable care program. To start, in case, to give some background, value-based insurance design is one lever that purchasers can use to drive towards value or to incent consumers to use value care that have high clinical value. Everyone who has insurance has a benefit design of it, and then this is a different type of strategy. Thinking of when every plan has a benefit design, but this is kind of a new strategy to think about how to maximize value from the benefits that you can include in your benefit design. So the aims of a value-based insurance design is to increase healthcare quality and decrease costs by using financial incentives to promote cost-efficient healthcare services and consumer choices. So these are some examples of services with high clinical value are primary care, preventative services, generic drugs, and then low clinical value. An example is emergency department use for non-acute services. So services that could be seen and treated in primary care. There are principles that we use when designing value-based insurance, when designing our benefit designs, and one is providing financial incentives or other incentives for preventative care, increase cost share for expensive services to encourage appropriate use, providing best benefits and coordinated care when using primary care, evidence-based chronic disease management, no cost shares for wellness and other services that help with chronic disease management, including diabetes monitors is an example, tobacco cessation, or use of telemedicine, phone, email consultations that makes it easier for members to access primary care. Then also no prescription cost shares for chronic disease maintenance or drugs and low cost for generics. So basically trying to make it as easy as possible for consumers to use the right care and high value services. The value is kind of the buzzword today where we hear about value so much. So I want to take a minute to talk about value-based insurance design versus value-based purchasing. The value-based purchasing is a financial strategy that holds providers accountable for cost and quality. And then both are two levers that a purchaser can use, but one could be used without the other. For example, I know a couple purchasers, they may not have a value-based payment strategy, but they are providing incentives through the benefit design to help consumers be better consumers and do value and consume value, in steering consumers towards services that are value to health. But our accountable care program is an example of a value-based purchasing or value-based payment model that we're using, and that we're also have designed the value-based, have used value-based insurance benefit design to drive consumers to the appropriate care. It's covered in a previous webinar, but for background, the Healthcare Authority launched an accountable care program for public employees in 2016 in the 5-county Puget Sound region. Our two partners under this accountable care program are Puget Sound High Value Network and the University of Washington Accountable Care Network. To date, over 10,000 PEB members and their families are enrolled to date and are seeking service are in one of these two networks. So when we created our benefit design strategy under the accountable care program, we used the same principles that I outlined, the design principles on a couple slides ago, but a key strategy we also used was to design the benefits to incent members to stay within those two networks. Those two networks are in a partnership or in contract with us to assume financial and clinical accountability for the defined population that are enrolled, and we needed to under our contract and in working with them, a key element is to incent those members to use those to either use, if they're enrolled in one of the networks, to use the network for their care. So so those networks can assume complete accountability for each of them. And as a reminder, our accountable care program is it can also be referred to as a narrow network. It's nested within our PPO products. So when we talk about in-network, we talk about, I'm referring to each of the different networks and their partners, but then out-of-network is the PPO network that it's nested within. This next slide shows the different UMP Plus, our accountable care program benefit design, but I also included our group health plans, which we are our HMO and PPO, which we consider value-based plans for public employees. Under both, provide incentives for preventative care, and some of that is attributed to the Affordable Care Act, where preventative care of a certain level are covered at no cost. For benefits for primary care, to incent use of primary care under our accountable care program, there's no cost for a member to seek primary care in network. And then we also have a higher copay if they go outside a network, again, to incent members to stay within the network that we've defined as a high-quality network. Similarly, under group health, they have low copays, trying to break down any barriers to primary care, or have no barriers to primary care, or as little as possible. For incentives for phone and email and telehealth, under our accountable care program, phone, there's a dedicated call center for members. Each delivery systems have different rules around email, but members under either network, the main partners have the email functionality. They can email their provider or care team. And one network has telehealth, Skype for free, where members can ask to speak with a member, a care team, provider, instead of going to the office, which helps get employees back to work faster. And under group health, they have phone and email is also free, and they've been a leader in member engagement and member email for a while now, or a leader in this region. For incentives for RX, there's no deductible under the accountable care benefit design, and then there's different tiers based on the value, and the group health is a similar one. The emergency department use, steeper, there's a copay. It's the only copay under the benefit design, the UMP Plus design, plus a 15% co-insurance to discourage inappropriate use. And under group health, they have higher amounts, but it's also waived if you're admitted and it's appropriate. The last thing is a wellness incentive to increase participation in our wellness assessment for public employees. Under the UMP Plus, there's no medical deductible if the wellness plan and follow-up are completed, which is very attractive to members because then there's just the lower premium they have to pay. And there's no incentive yet for group health plans, but that's an area that for further exploration. Next slide. So how did we design our the benefit package for the accountable care program? Well, Group Health has been a true partner and a leader in value insurance design. So this hasn't been a new process for the Healthcare Authority, but so this is what we did under developing under the Accountable Care Program. You know, it was a similar process of as we've done for the other PEB plans. We also took learnings from Boeing. Boeing has been the leader in working directly with providers and creating an accountable care product. They, in Mercer, also helped them, and they were very, very open and collaborative of sharing how their benefit structure, which we model our benefit structure after. We also, our actuary is very much involved throughout the process. So it's not just throwing together incentives. There's a lot of things to think about when you set no payment for primary care, and we have to see how that affects our PEB rates. So our actuary is very much involved and a very helpful partner in helping figure out, how does it affect our rates? How does it affect how everything kind of has to align. And I'm sure other employers work, actuaries are very much involved in helping them set their benefit design. I want to talk a little bit about member education. So in addition to creating a different, paying differently, having a different contract with providers, and then also aligning the benefit design, we also, in order to maximize value, the triple aim, we are trying to align member education at the same time. So as we've embarked on our accountable care program, we have accelerated or built on our member education efforts. So over the last year, we worked with the Washington Health Alliance to develop the Savvy Shopper campaign, supported by our Healthier Washington grant, which is available on the Healthier Washington website. It's phenomenal. Anyone can use it, any employer can use it, and for free of charge and put on their website. But it talks about it talks about value in plain speak, and what shoppers should be looking for and how to look for value. We also created new newsletters and the PEB news to talk about value, because this is a new concept for public employees. And that we did that over the summer to kind of gear up for summer 2000, last summer, in advance of open enrollment in November. We also created a UMP Plus kitchen toolkit to also help educate members on the new offering of UMP Plus, its benefits, and to educate and engage members. And these are just a couple of things. Each of the different health plans and the different networks did their own direct marketing, but member education is a key part of this, and we recognize it, and it's an ongoing part of our work to drive value to members. I'm going to turn it over to Dr. O'Neill now to talk a little bit about value-based benefits and the roles of different stakeholders.
Thanks, Rachel. This is Mary Kay O'Neill, and happy to be here today to add my thoughts here on the issue of value-based benefit design. And I think it's important to have a clear viewpoint about the benefit design aspect of getting to the triple aim goals on top of the value-based purchasing and the specific terms and arrangements that are made with those delivering care to the state employees or other employees or members of the community. So may I have the next slide, please? So I think it is, you know, I have been in the insurance end of the medical world for a number of years, as well as delivering care and sitting at various seats of the table. And I think it is important to remember that benefit design is a key way to both communicate and direct how people who have benefits seek care. And so it is very important that in the thoughtfulness that goes into benefit design, people are really thinking about how do we promote the right kind of care for people, which is where I think the term value really comes from in this whole dialogue, so that things that Rachel has pointed out, such as dropping barriers to preventive visits, to incentivize folks around their own participation in their health, all of those kinds of things, I think, are not just designing it to make it possible, but are really trying to clarify how important those things are to individuals. And that then that there would be a careful look at those things in the healthcare delivery system that do not add value, and to make it more difficult either to access it or to make the decision to go down that path. One of the examples I've been working on with employers lately is the idea of centers of excellence. And this is a kind of an interesting thing to try to match up with accountable care organizations. These are really areas of clinical delivery that different delivery systems have put together around often procedures to really do a very careful job about identifying the correct people to receive the procedure, to design the procedure to be safe and effective, and to take responsibility for any outcome over time. And so people that receive care in such a center of excellence often can have a better outcome. There can be less cost for the whole episode, and for working age adults, they often can go back to work more quickly. So another thing that Rachel mentioned earlier is this idea that ACOs are kind of an evolved version of a neural network. And so that is where benefits are designed around an organization who has made the investment and built the infrastructure to prospectively manage a population of people in ways that advance their health status over the time that they receive care there. And that's really a lot of the work that's going on in ACOs right now. And I would have to say that there's some people doing some tremendous work around this. I'm not sure any of us are at the finish line on that process, but really understanding how to get the right care, the right information, the right access to folks when they need care or when they're in the midst of making an important healthcare decision, in order to have assurance that the investment made in their health is valuable to them and to the community. And then I think this incentivizing people to participate in activities, whether it's compliance with management of chronic conditions or involvement in their own wellness status and preventive efforts, is a key differential in terms of really having a value-based system in place. May I have the next slide, please? So as I've done work in this area, I think it's important for me even, to make sure I'm clear on which stakeholder I'm talking about when I talk about different aspects of this, because this is really a wholesale change in how healthcare is delivered. And there are roles for everybody at the table to make sure that value can be gained out of the investment that everybody's making. And I think Rachel and the Healthcare Authority are a good example, as is Boeing and some other employers, are really taking the time to think carefully about how to design benefits for their own employees, dependents, and early retirees to make sure that people are getting the care that they need. So I think without that kind of purchaser sponsorship, it's very difficult for the rest of the community to move forward. We are in the midst of trying to figure out what model or what different models are valuable to the community. And I think, as people know, both the Healthcare Authority and Boeing have gone out with some direct contracts with delivery systems. But there are also a large number of employers who probably don't have the capacity to engage at that level for their employees, but certainly are looking for the benefit of this type of care delivery. And so health plans have been putting together ACO offerings as well. So if they're doing that, of course, they need to be able to have the kind of contractual relationship and oversight relationship with the delivery system to make sure that they are delivering on the value-based promises. And they have the responsibility most often to hold the relationship to the subscribers so that they really understand what this product is and how best to utilize it, and what the implications are for the individual in terms of their health outcomes and their financial outlay. And of course, there's a huge amount of work being done in the healthcare systems right now, trying to make sure that the information infrastructure is in place, the clinical decision making is consistent, the access is in place for people, to make sure that the quality metrics that are part of the arrangements are met, the customer satisfaction, and the management of the trend for the expenditure for the populations that they're responsible for. So may I have the next slide? And I've been to quite a few meetings over the last several years on this topic, and I think a lot of emphasis has been placed on the capabilities of the delivery system, and also even some to making sure that the benefit design is good. And sometimes I feel like we've been a little bit slower to think about what is the real educational engagement strategies that are necessary for the patient in this. I think this is a little bit based on the foundational history of the medical home in our community, which was really something that was between the purchasers and carriers and the delivery system, and didn't require active choice by the patient or the member. But in this model with the ACOs, most of the time they have an option of actually choosing this as their benefit design during an open enrollment, although we do still have what are called attributed members going into these arrangements with people that have established care with a particular system. But it is really key that people have very good access to information about how this kind of plan works, and that they have a good understanding of their opportunities, for example, to save money on their deductible by participating in wellness, as Rachel described earlier, and that they understand, you know, the incentives to stay within the system and complete their screening exams, and the advantages given for compliance with care for chronic conditions. And I think that the proof in the pudding in the long run is really going to be as all the different stakeholders develop their skills and capabilities. The issue of customer service is going to be important, because I think the real impact on populations over time is going to be where a person can get care from an entity who really gets to know them and know what their issues are. And I think people will stick with an organization if they really feel like the service they're getting is good and that their situation is understood. So I think those are some of the deliverables that will be occurring over the next several years with the ACOs in the community. So next slide.
Mary Kay, I think that concludes your part of the presentation.
Yes, I think back to you, Rachel.
Sure. So a couple of questions came in. I'm going to read the question, and I'm going to try to respond, and then Mary Kay, if you have anything to add, just jump on in. Okay. The first question, and thank you very much for these questions, they're great. One is, Are there plans to add value-based design principles in the Apple Health Medicaid program? That's a really good question. So right now, there's no cost sharing. I shouldn't say right now. There's no cost sharing in Apple Health. So it's a little tricky to do value-based design in Medicaid. We have no plans to add any additional cost sharing. We are currently pursuing an 1115 waiver under Medicaid, but so these concepts don't they don't. What I've talked about today is really on the public employee, the state employee side of things. But one thing that we are working on between both of the public employee programs as well as Medicaid is member engagement, and how do we get, whether they be a Medicaid beneficiary or a state employee, or public employee, how do we get them better engaged in their health and to own their health? The second question is, the copay for ER is very different between the ACO and group health. Do you see a big utilization difference? I can't answer that because the Accountable Care Program has only been live about 6 months, not even, and we're just getting data on utilization and costs. So hopefully if we do another webinar like this next year, we'll have some good findings to share. Mary Kay, do you have any insights that you see between that you want to add on that to the question?
Well, in the grid they had $75 plus co-insurance, so it was a little hard to see how much that actually would be out of pocket. My guess is that it actually trues it up pretty well. I will say I think the ER costs waived under group health may be called out because the group health ER is not directly attached to a specific hospital. Nobody's charged ER if they're admitted in the regular health plan sense of things. But this is an area, of course, of a lot of emphasis within the delivery system, because if they're trying to manage trend, any ER charges go against their own financial performance. So they're working pretty hard to try to avoid that. But this benefit design is an opportunity to align the implications to the member patient with the implications to the delivery system. And I think Rachel's entirely correct. Where things are now based on what the plan design looks like needs to be evaluated after there's a year of experience.
Thank you, Mary Kay. The third question that came in is, how do you define a high-quality network? This is in reference to your narrow network. Curious if there are specific measures involved. This is also a really great question. How we're defining quality is we've developed, or a committee that was appointed by Governor Inslee are recommending measures to use to measure quality, called the statewide common measure set. And so in our contracts with both accountable care networks, as I mentioned, they're accountable to for the costs and holding costs under a guaranteed trend, but they're also accountable for achieving certain, or making improvements, and will be rewarded financially for their performance in 19 quality measures, and those 19 quality measures are taken from the statewide common measure set. I will, when we did the procurement for these accountable care networks, I want to point out that this is hard work for providers and delivery systems. They've made a lot of headway on quality measurement over the last couple of years, but it's difficult the narrow networks is a difficult topic, and maybe Mary Kay can elaborate some more, but we are working directly with these two delivery systems because they've agreed to enter in the two types of contracts, and they have shown good faith efforts to to deliver high quality costs. But there's other clinically integrated networks out there that are also working hard to measure quality, but our definition is based on the performance on the Washington State Common Measure Set, which is available for more information on our Healthier Washington website.
Well, pretty much, I think from a philosophic perspective, value is defined by the triple aim. So there's a financial value, which is managing trends. There's quality value, which is, meeting the quality metrics, which the common measure set represents a large body of work, I'll tell you, across many professionals in the state who met to talk about this, but largely reflects pretty much the national standards around quality. And then the third component of value is customer satisfaction measures, usually measured by the CAP survey. There are other aspects of value as well. Really, there's access, making sure people can get in and be seen well. And there's some examination of most of these systems in terms of their capacity to outreach and manage people with complex medical conditions. So this isn't, I don't think there's been every I dotted and T crossed on the definition of what value is, but I think, people understand that there are all these components in play when you look at the investment that the community really makes in the health of individuals. And, I think that the standard body of work for all these delivery systems is on the three aspects of the triple aim.
Thank you, Mary Kay. We had another question come in. Can you speak more about the state's goal to have 80% of state-financed health care to be purchased through value-based payment arrangements by 2019 or 2020, which now is 2021, if we get the waiver? How do you envision that playing out? We set an ambitious goal for ourselves under Healthier Washington, and we know that. As of right now, or in April 2014, we did a survey to plans and providers, and it seems as though they're across the board. Health plans were 25% there, maybe, rough estimate, and providers were 20% there. 2019 is only 3 years away, but I think that we are in a critical time in healthcare, and with Medicare having very similar purchasing goals that they've compelled themselves to. By 2018, Medicare wants 50% of their payments into payments with the quality or efficiency that are linked to quality and efficiency. And given that they have that ambitious goal, and the Medicare Access and CHIP Reauthorization Act, which is also known as MACRA, that has come out and is reforming the way that Medicare physicians will be paid under Medicare. I do think that it's a long journey, but there's a lot of the things are pointing in the right direction nationally, and that we hope we can achieve that goal, and we're tracking it closely.
I agree, Rachel. I think even though there's been this huge amount of work and it's not at all easy, I really think with the push from CMS, the push from you guys, and actually the push from the commercial purchasers in the state all aligning, I think that it may be an ambitious goal, but it's not, beyond understanding of where we'll be by 2020.
Thanks, Mary Kay. I don't think we've gotten any other questions, so we might wrap up and give folks some time back. So thank you very much for joining this webinar. as a reminder, we have posted copies of our accountable care program contracts, and the website's there. There's not much about the benefit design. Is not in the. There's not a lot of information on the benefit design in the actual contract, but there is some language that the healthcare authority agrees to provide financial incentives through the benefit design to encourage member use to in-network use, as well as other primary care incentives. For more information, feel free to email me, and or Dr. O'Neill, I'm sure, should be willing to answer any other questions. And I just want to close by thanking Dr. O'Neill for her time and reminding folks that the next webinar is July 11th from 1 to 2, which will do a deeper dive on the quality improvement model. And you can register on the Paying for Value website on the Healthcare Authority's Healthier Washington website. Thanks you.
So much, Rachel.
Thank you, Mary Kay. Have a good day.
Okay, take care. Bye.